Well, Surgeon Dr. Emil is there, and today I am here to discuss the antibiotics on the surgical floor. The main purpose of this video, the learning objectives, you must know the types of the antibiotic protocols. That's the prophylactic, empirical, and therapeutic. And type of wounds, you must know about the clean, contaminated, and the dry wounds. And the most important thing here, you must know the indications of the antibiotics according to the wounds. So don't use antibiotics blindly, otherwise you will cause the resistance and there will be a lot of issues. So the most important thing, the risk factors for the surgical site infections. Remember one thing, some of the factors, they are modifiable and some of them they are not modifiable. Like in case of the patient risk factors, the extremes of the age, you cannot modify this risk factor. Poor nutritional status, you can improve the nutritional status and you can control the obesity. You can quit smoking. You must have the good control on the glycemic controls, and coexisting infections at other sites you must treat, and bacterial colonization, for example nares, and colonization with the staphylococcus aureus. And if immunosuppression is there, this is also the risk factor for the surgical site infection, and prolonged post-operative stay. In case of the operative factors, length of the surgical scrub, it matters a lot. Why? The recommended length of the surgical scrub during the first operation of your first day, it's 5 minutes, and this is the minimum. And after every operation for the subsequent operations, it's at least minimally 3 minutes. And if I discuss about the skin antisepsis, about this fact, okay, most of the time we use pyridine solution for the antisepsis, and its onset of action, it's 3 to 5 minutes. It's not like that you just paint the area and after that immediately you start your operation. And pre-operative skin preparation and shaving, the world has moved towards the clipper, so you must use the clipper. And length of operation, some of the surgeons, they will say you that length of operation does not matter, speed does not matter. This is wrong. Length of operation matters a lot. If the length of operation is more, then it's a risk factor for the surgical site infection. And the antimicrobial prophylaxis, if you give, then the risk factor will be eliminated. And if inadequate instrument sterilization is there, then this is also the risk factor for the surgical site infection. And if foreign material in the surgical site, and if we have put the drains, this is also risk factor. And the post-operative hypothermia, so avoid the patients, so treat, so you will use the warm blankets or you will use any method to prevent the post-operative hypothermia. So now you must know what is the prophylactic antibiotic, administration of the antibiotic in the absence of the known infection. So you give the prophylactic antibiotic for the prevention of the infection. So it's not used to treat the infection. It's for the prevention of the infection. And you have the choice of cephalosporins, and if documented allergy is there to the penicillins or the cephalosporins, then you will shift to the vancomycin. Otherwise you have the option of the best choice, it's the cephalosporins. And regarding the dose, a single standard therapeutic dose of the antibiotic is sufficient. And for all the surgical procedures, the route, it will be IV route. And timings, when will you give it? You will give it within 30 to 60 minutes before giving the incision, and as close to the time of incision as practically possible. So you must have the concept of the decisive time and other things. This is behind the scope of this lecture. So in case of the prophylactic antibiotics, you will consider redosing. Why and when? if your procedure is more than 4 hours. Okay, and if it is taking longer than 2 half-lives of the antibiotic, and if blood loss in adults it's more than 1500 ml, you will consider redosing. You will give another dose of the prophylactic antibiotic in this case. And duration, for the clean procedures you will give only single shot. You will give only single shot of that antibiotic. For the clean contaminated cases and contaminated procedures, your prophylaxis it will continue for 24 hours, and it should not exceed 48 hours. And if it is up to the 48 hours, that's the extended prophylaxis. So prophylactic antibiotics, this is the chart. You can take the snapshot and you can memorize all these. Here we have explained what we have explained the specific operation. Like if we are doing the procedure for the esophagus, then the organism will be the Staphylococcus aureus or the Streptococcus, and antibiotic of the choice it will be cefazolin. And in case of allergy to the first line drugs, then you have the option of clindamycin and gentamicin, and dosage is 1 to 2 grams. And if you are doing the thoracic procedures, then most commonly organism it's the Staphylococcus aureus or the Staph epidermidis. Again you will use the cefazolin, that's the cephalosporin. In case of allergy you will use the clindamycin and its dose is 1 to 2 grams. In case of the gastroduodenal, the gram positive cocci are there and the gram negative bacilli are there. Again you will use the cefazolin, and in case of allergy you will use the clindamycin and gentamicin. Again dose is 1 to 2 grams. And in case of the colorectal surgery, enteric gram negative bacilli are responsible, and you can use the oral neomycin and erythromycin base. And same as if allergy is there, you will use the clindamycin, gentamicin, again 1 gram oral. In case of appendectomy, the gram negative bacilli are there, and you will use the again cephalosporin. In case of allergy you have the option of using the clindamycin. In case of the biliary tracts, enteric gram negative bacilli are most common organisms, and you will use the cefazolin. In case of allergy you will use the clindamycin. Vascular surgery organisms, they are Staphylococcus aureus epidermidis, enteric gram negative organisms, and you have the option to use the cefazolin. In case of allergy you will use the vancomycin, clindamycin. And finally at the last, the breast and the hernia, the organisms are Staphylococcus aureus, Staphylococcus epidermidis. You have the option to use, and this is the antibiotic of choice, cefazolin. Again in case of allergy you will use the clindamycin, and its dose is 1 to 2 gram. So concluding from this, you can say that from this slide, that most commonly you use your antibiotic of choice, it's the cephalosporin, and alternatively in case of allergy you will use the clindamycin. So moving towards the next slide, again the zoomed in view of previous slide. Now the prophylactic antibiotics, there are some guidelines in which it's highly recommended. So in case of appendectomy and the colorectal surgery, it's highly recommended to use the prophylactic antibiotics, and only recommended in contaminated head and neck surgery. Okay, esophageal surgery, stomach surgery, duodenal surgery, small intestine, bile duct, pancreatic, liver and open gallbladder surgery. And it should be considered only in clean malignant head and neck surgery, in neck dissection, in breast surgery, and it's not recommended in clean, benign head and neck surgery, laparoscopic gallbladder surgery, hernia repair with or without mesh. So it's not recommended. Most, although we are using in our country, there are reasons I will tell you at the last. So moving towards the next slide. Now the empirical antibiotic therapy. What's that? Administration of the antibiotic when there is a strong possibility but unproven established infection. So you don't know about the exactly about the organism. And empirical antibiotic, the choice, it's broad spectrum. It's always broad spectrum. And it's according to the expected flora. And its dose is standard dose of that antibiotic, which depends upon the half-life of the antibiotic. And its route, again the route is same, that's the IV. Okay, and timing, it's according to the half-life of the antibiotic, and you will continue till culture report is negative. So you will start the antibiotic and you will wait for the culture report, and you will change according to the culture report. Now the third, that's the therapeutic antibiotic therapy. It's the administration of the antibiotic when an established infection has been identified. Now the choice, it's according to the culture sensitivity report, and again its dose is standard dosage of that antibiotic, and again same, you will use the IV route, and timing, it's according to the half-life of the antibiotic. You can use it in a TDS, in a BD, in OD dose, in stat dose, so it depends upon that. And mostly its duration is 5 to 7 days and 2 to 3 weeks in pancreatitis and the diabetic foot. In some surgery, like in orthopedic surgery, they can use for months. So in general surgery, most of the time we use for 5 to 7 days. So therapeutic antibiotics, in case of the abdominal trauma, in case of the perforated viscous, you will use the third generation cephalosporin. In case of abdominal trauma, again you will use the third generation cephalosporins. In case of breast abscess, you will use the cloxacillin. In case of prosthetic graft infection, you will use the third generation cephalosporin. In MRSA, you will use the vancomycin. In infective necrotic pancreatitis, you will use the meropenem, ciprofloxacin and metronidazole for 14 days. For peritonitis, you will use the ceftriaxone or moxifloxacin for 5 days. For laparoscopic procedures, there is no need of the antibiotic. Remember this thing. Again, now moving towards the next slide. Now we are discussing about the 4 types of the wounds. So first is the clean wound, in which no acute inflammation is there and no viscous has been perforated. There is no transaction of GI, GU, biliary or respiratory system, like for example, in case of herniorrhaphy, like vascular surgery, thyroid surgery, breast surgery. These are all surgeries which are considered clean wounds. So I will tell you that there is no need to use any antibiotic. Even you cannot use the prophylactic antibiotic in these cases. Then there comes the clean contaminated wounds. These wounds include when there is controlled opening of the GIT, GU, respiratory or the biliary system, and there is minimal spillage of the contents. For example, in case of the resection and anastomosis of the gut, where there is no perforation of the gut. In case of cholecystectomy, in case of uncomplicated appendectomy. So these are the examples of the clean contaminated wounds. Then you have got the contaminated wounds. What are these wounds? Includes the wounds in which there is maximum spillage of the contents, and for example typhoid perforation, tuberculosis perforation, DU perforation. In all these cases they are considered contaminated cases. And finally at the last, dirty wounds are there in which there is purulence or the abscess at the operative site, like firearm injuries or any other penetrating trauma for more than 4 hours old. So at the end, so concluding the things, what is the indication and where it is indicated? In case of the clean wounds, antibiotic use it's controversial. Most of the people, most of the times in the literature it is written don't use any antibiotic. In case of the clean contaminated cases, antibiotics are used for the prophylaxis. In case of the contaminated cases, antibiotics are used for extended prophylaxis. And finally, in the dirty cases, the therapeutic antibiotics are used for the treatment. But you might be thinking that in our setups we are using the antibiotics, therapeutic antibiotics, even for the clean cases, even for the clean contaminated cases, even for the contaminated cases. So this practice should be adopted according to the protocols. Although in our country the sterilization techniques they are not up to the mark, but you cannot cross the extremes. You can use the prophylaxis in case of clean cases, extended prophylaxis in case of clean contaminated cases, and therapeutic antibiotics in dirty and as well as in the contaminated cases. But this is not the justification that in case of the clean cases you are using the therapeutic antibiotics. So this is not indicated. So finally concluding the things. So thank you so much. If you have learned something from our videos, then do subscribe our channel Surgeon Dr. Miglani, and don't forget to press the bell icon for more updates. So thank you so much. Do subscribe our channel by clicking on the red button below, and don't forget to press the bell icon also.